webinar. Which we started last year in June, and we have done 6 AFOMP School webinars in 2021, in addition to the AFOMP monthly webinars. The first webinar of this 2022 will be from Professor Dr. Thomas Kron and his group. Again, next month, we have AFOMP School webinar on 11th, and as well on the 26th of the February, the AFOMP School webinar will be there. The program for the AFOMP webinars is already on the AFOMP website from January to June. AFOMP School webinars have been finalized for this coming 6 months, and they will be on the AFOMP website. So this is a second webinar from Professor Thomas Kron, whom you know very well. He is the chair of the science committee of the AFOMP, and IMPCB huge contribution. I will not waste time in introducing. So today's AFOMP School is on medical physics and advanced cancer services. It is on stereotactic and spatial techniques in radiotherapy. And there are 4 speakers. Professor Thomas Kron will be giving the introduction and the brief of the session 1, how it went, the response he has got, and the feedback. The second will be from Atousa Montaseri on Linux and or Gammaknife. Then the third talk will be from Adam Eo on Saber beyond lung, vertebral metastasis and liver. And the last talk will be from Peta Lonsky, which he had earlier also given one webinar for the AFOMP, special procedure of TBI and TBE. And these are the eminent speaker. The folder is available on the website. You can put your questions in the chat box, and the moderator will take up these questions when they will have a discussion. With this short introduction, I hand over the floor to Professor Thomas Kron to start the proceeding. Professor Thomas Kron, the floor is yours.
Thank you so much, Arun, and thank you all very much for joining. I hope that we will be able to present something in the next 1.5 hours, which is of interest and which will help all of us to understand our chosen field, the wonderful field of radiation oncology, medical physics, a bit better. I will now share my screen. And let me just, you should now see the AFOMP Summer School sign there, and I will now go into presenter mode. Here we go, and let me just see. Okay, that's great. So Thank you so much for joining us for this summer school. And this being a school is really trying to talk about not the greatest and absolutely latest, but about things which are currently happening in the clinic. It is also about services. And you can see that the idea of these lectures is centered around patients, about patient care, and in this case, advanced patient care, which basically means the involvement of medical physicists is absolutely essential. It is also meant to be at least moderately interactive, which is something which is difficult in these webinar environments. But I would like to encourage you to really contact us through the chat, through email, or through any means you may feel important, because I think the idea of a community of medical physicists coming together, trying to learn or work on issues together is really something quite important. It is quite important in the context really of continuing professional development. And as we all know, one of the most important things for medical physicists is that we are always at the cutting edge, always at this Pareto surface of technology and techniques. And therefore, as this changes all the time, it is important to maintain currency of practice, currency of knowledge. And this is what these lectures are really all about. Just very quickly, we are trying to just tell you a bit about what we are doing at Peter MacCallum Cancer Center, which is sort of rather large and rather fortunate in terms of the availability of a whole variety of different bits and pieces of equipment. And we take you, after our first lectures, which were more about radiation safety and quality assurance sort of in general, to somewhat more closer to this Pareto surface with stereotactic irradiation and special procedures, total body irradiations and things like that. It is all about patients, and we treat about 7,000 patients every year. These summer schools are really centered around the idea of trying to cover a large number of topics or tidbits of knowledge, and we started off last time with radiation safety and quality assurance. We are now looking at special procedures and then move later on in the year to imaging and data for therapy and close off with some brachytherapy. The idea is really that these lectures are meant to be practical, pragmatic, and they are delivered by people who actually do the work, not academics, but people who are working on the shop floor every day with the stuff we are talking about. And at the end, like last time, we will hand out some questions to the work which was presented. And these questions, they are in a format which is the format you would encounter in the American board certifications, but also in IMPCB, the International Medical Physics Certification Board. If someone would like to get certified, these questions are modeled exactly on what that these things look like. This is an example question here in the corner. They always have 5 answers. It's multiple choice. Only one of the answers is correct, and hopefully fairly quickly to answer overall. In our environment, you will need to answer 60% of all the questions from all these 4 sessions correctly, or basically 20 correct answers out of 32 overall possible ones. These were the questions of last time. Last time we talked about medical clinic QA, radiation safety overall, and the rationale of radiotherapy, which is basically in radiobiology. And just as a reminder, these were the questions, and you can sort of quickly have a look at it and remind yourself, is that something which just rolls off the tongue? How do we need to consider oxygenation in radiotherapy? And what is the typical half-life for repair in mammalian cells? I think by now you should really know all the correct answers. The reoxygenation in radiotherapy needs to be taken into consideration by ensuring that the treatment course is long enough to allow for tumor reoxygenation so the tumor becomes radiation sensitive again, and that's typically of the order of a week or so. Well, the typical repair half-life in mammalian cells is somewhere between minutes and hours, and if the half-life is an hour, then if we want to ensure complete repair, we need about 6 hours, 6 half-lives or a bit more, which basically means overall that we have between fractions a couple of hours.
Just interrupting you,
yes?
Some noise actually because of your microphone. Lot of humming noise is coming.
Oh, I see. That was a problem we had before. Is that better if I take my microphone closer?
But there is some humming sound in the background.
That is my computer, which has a fan which doesn't work. Can you still hear me? I might.
Yes, but yeah, but some sound was there. Okay, continue then.
Yes, my apologies. I won't be too long. I just wanted to provide you some feedback here. It was good to see that virtually everyone got things right with the typical repair half-life overall. QA and audits also was answered typically quite right. The occurrence and severity and detectability are the parameters assigned for failure mode and effects analysis or risk management in QA. If something goes wrong by QA, then obviously we do not treat patients. And that is really something everyone got right, which is great to see. The radiation safety questions were proved to be a bit more difficult, and we had about 30% of participants answering some of the radiation safety questions wrong. And I think this is actually really something which is quite important for us to know also in a schooling or CPD sort of sense, because it does mean that AFOMP can target future summer schools or future lectures to try and fill these sort of gaps in knowledge. Overall, however, we would like to thank all the participants, and we had 43 answers. I hope we can get more this time, and I will circulate the questions after all the lectures have been given overall. I think it is something which is important to provide us with feedback. Do we ask the right questions? Do we provide the right information which is valuable for you as the audience? And that is really the most important thing, that you get something out of all this. So this is what we are doing today. After the very nice introduction of Professor Chugul, I've now finished my humming noises and the introduction to this session, and we are starting off with SRS, Linux, and or Gammaknife, and Atousa Montaseri will provide that lecture. And Atousa is our Gammaknife physicist. We are fortunate to have a number of people who are sort of specializing in stereotactic procedures, and we installed a Gammaknife about a year ago. We're still learning, and Atousa has started to provide in-services to other physicists and teach us what is there to learn in terms of the physics for that. And I think it is particularly interesting to contrast the Gammaknife treatments, which is considered by neurosurgeons the gold standard for neuroradiation procedures, with what we all have access to, linear accelerators, or most of us have access to linear accelerators, which obviously are also widely used for stereotactic procedures. So I'm very happy to hand over now to Atousa for lectures on SRS, Linux, and or Gammaknife. Thank you.
Thank you very much, Thomas. Hello, everyone. I'm going to share my screen. Good morning or good afternoon, and thanks for joining us today. I'm going to talk about stereotactic radiosurgery, Linac and Gammaknife. Okay, in this short presentation, I'm going to talk what SRS refers to, talk about the definition of SRS, the aim of the treatment, intracranial targets that we treat, techniques including Linac and Gammaknife, the procedures, and the role of a physicist. I think I have to start this talk by talking about Gammaknife first, because stereotactic radiosurgery started with Gammaknife, and we cannot talk about Gammaknife without talking about Lexell, who was a Swedish neurosurgeon who developed the term stereotactic radiosurgery in 1951 as a new concept of a non-invasive method to treat lesions which were not operable or were not accessible by surgery. So Lexell built his first Gammaknife machine in 1968. The first version of Gammaknife was introduced, and then decades after, new versions were introduced. At the moment, the latest version of Gammaknife is called Icon. I'll introduce Icon a bit later. Then in 1980s, Linux started to do Gammaknife, started to do radiosurgery, and they had to do some improvements and developments before doing that. So basically, stereotactic refers to a procedure in which points and locations inside the brain are localized using an external fixed three-dimensional reference system, such as a rigid head frame, to perform a neurological procedure in a minimally invasive manner. So basically, you don't want to open the brain, you don't want to cut the skull, you just want to do a minimal invasive procedure to treat the target. So the stereotactic frame serves two important purposes. One is immobilization and the other one is localization. What you see here is the G frame from Gammaknife, and the new one, this blue one, is the Vantage frame, which is the new version of the frames being introduced by Alexa. So what a frame does is defining a 3D Cartesian coordinate system. It means somewhere in the space or somewhere in the patient's brain, you'll have a point where is the origin of the coordinate system, x, y, and z equals 0, and then everywhere else in the brain, you will have an address, like every point can be defined with x, y, and z, and you can localize the target. So every pixel in your image will have a stereotactic definition. A Gammaknife typical frame-based treatment is usually starting with a rigid application of the stereotactic frame to patient's skull early in the morning. So that's actually a long day for patients. Starting with local anesthesia and putting pins and screws to skull and fixing the frame around the head. And then once the frame is fitted, patient goes to an imaging department. In our workflow, it's always MRI first, and then CT scan, and then if patient needs angiography, they go to angio department. All this imaging is done with frame attached to skull, and frame shouldn't move at all. Then images are required and sent to the treatment planning system. The main or primary image data set that we use for Gammaknife planning is MRI. Then ROs, or radiation oncologists, delineate the targets and organs of risk on the MR images, and then treatment plan is created. Then we have a checklist. The physicists in our department do a comprehensive plan check to make sure that plan quality is optimum and the plan is safe and accurate to go ahead. Once we're happy, the patient is attached to the Gammaknife couch and treatment gets started. But before being on, we can perform a cone beam CT. That's a surprise. This new Gammaknife version has a cone beam CT, and we can use that to verify the patient position, actually the frame position. We want to make sure that there hasn't been any movement in the frame and there is no frame slippage. Once we're happy with the images and we verify the patient position, target position, we go ahead. Just a quick introduction to Icon. As I said, this is the latest version of Gammaknife machine. It has 192 cobalt sources, which are distributed in 8 sectors around the gantry. Each sector includes 24 sources. And as you see, these holes here in these collimator are actually different collimation or different collimator sizes. You can collimate your beam with 4 mil or 8 mil or 16 mil apertures, or you have the option to block that source basically. And this machine has a cone-shaped design. All the sources are stored at the back of the machine in a vault. And then, unlike the previous Gammaknife versions, where the sources were stationary and helmets were had to be attached to the patient head, in this machine, collimator is fixed and sources are moving. So when you want to treat the patient, there is a drive mechanism that pushes the sources from the back of the machine towards the collimation system, and then the treatment goes ahead. So these sources, when manufactured, actually according to the source license that we got from manufacturer, the total activity of our sources was something about 5,000 curie. And when we calibrated the machine and measured the dose rate at the center of the Gammaknife gantry, we measured something about 3.38 gray per minute. So that's all about the, that was actually a short introduction to frame treatments on Gammaknife, but with this version of Gammaknife, we can do mask treatments as well. So people get surprised, what is a mask doing in the Gammaknife? Everyone thinks we always have to do frames, but no. If the target is a bit large and you don't want to treat in one single fraction, you want to fractionate. You want to split the dose into smaller parts to spare normal tissue and not get side effects. You can go for fractionation. But fractionation is not possible with a rigid frame. You cannot put a frame on somebody's head and expect them to tolerate it for more than a few hours. And also you cannot put a frame on multiple days on somebody's head. So we have to go for kind of relocatable or reproducible immobilization system, which is a thermoplastic mask. But we know that the mask is not as rigid as a frame. There is no pins and no screws. So because there is still a little bit of room for patients to move their head, you might get interfraction and intrafraction motion. So you need a motion management system. You should be able to track the patient's head movement. So this machine allows us to do this, real-time motion tracking by means of the high-definition motion management camera. This is actually an IR camera, which is located at the foot of the couch. And you put a surrogate, which is an IR reflective marker. You put it on the patient nose, and there are some reference IR markers located at the two sides of the head, and the machine can track the motion. This is a case from our Gammaknife service. This was a patient with primary malignant melanoma, and then he developed brain cancer, brain met. It was a single target, diameter about 1.2 or 3 millimeters. They didn't want to go for frame treatment. They wanted to do mask because frame installation is not easy. It's minimally invasive. Some people don't want to do it. So the radiation oncologist decided to keep this patient in the mask. The dose was 20 gray, prescribed to one fraction and to 57% isodose line. As I said, immobilization system is masked and motion management monitoring is being used. So we do, our physics actually does a patient plan check. We check the accuracy of the stereotactic reference definition for mask and for frame cases. We check the dose distribution, we look at the conformity indices, gradient index coverage, we look at the dose delivered to OAR, and a couple of different parameters. We look at the DVH and the dose follow-up and the hotspot inside the target, and then once we're happy with the quality of the plan, we go ahead. As I said, this is how the IR camera tracks the motion during the treatment. We can set a tolerance or the threshold for this motion. There are lots of literature about this, how this threshold should be decided. We are at the moment we're using 1.5 millimeter threshold and the no-skip marker, and the Gammaknife can track the motion, can stop the treatment if the threshold is violated, and then can gauge the treatment. It allows you to adapt the plan to the new position. So basically this new Gammaknife allows for plan adaptation for mask treatments. What kind of targets we treat in Gammaknife? These are always small intracranial lesions, malignant or benign. We can also do functional disorders. These are the typical doses that we prescribe, usually prescribed for 50% isodose line, but this prescription isodose depends on the target size and target shape as well. Just as a comparison between SRS and the normal functionation IMRT or VMAC prescription. We know that in normal functionation, we prescribe those 100% isodose, and we aim to cover the target with 95% isodose line. According to ICRU recommendations, dose homogeneity that we look for is something between 95% to 107%. We don't want hotspots above this, but in SRS it's a bit different. In our LINAC service, we prescribe normally to 80% isodose, and in Gammaknife usually to 50% isodose. It means there is a hotspot inside the target, and that's the nature of SRS, the way that you create the plan. And when we do the plan check, we always look at this hotspot to make sure that it's not too hot and it's not too big. This is something that if we find suspicious, we talk to radiation oncologists to see if they're happy with that or they want to change the plan. So back to the definition, stereotactic radiosurgery is strictly defined as radiation therapy delivered by means of stereotactic guidance with approximately 1 millimeter targeting accuracy to intracranial targets in 1 to 5 fractions. So you want a very high targeting accuracy because you don't want to put your high dose, which is an ablative dose, somewhere out of the target in the normal tissue. You want to make sure that the high dose is being geometrically put inside the target where you want to eradicate the cells. There are major features in SRS. Large dose in few fractions means this actually results in high biological effective dose, which is high enough to produce self-healing and eradicate the target or the tumor. You want minimum normal tissue toxicity, and this is achievable by means of transformation of high dose and rapid follow. So to compare conventional radiotherapy, now I'm talking LINAC and Gammaknife, with SRS. In SRS treatment, we go for general increase in the number of beams. We want to achieve high conformity, so we have to go for increased number of beams. In Gammaknife, you use 192 cobalt sources. It means you're actually using all of these angles to hit the target. It's a very narrow beam. You put minimum dose into normal tissue, but you conform all of the dose into the target that you want to put. Then you go for non-coplanar beams. Gammaknife by design is non-coplanar because of its cone shape distribution of the sources, and LINAC can rotate the couch to give you non-coplanar beams. So you achieve, as I said, inhomogeneous dose distribution. LINACs, before being able to do stereotactic radiosurgery, had to improve their hardware to be able to conform the dose. Traditionally, LINACs had X and Y jaws, and they were able to open rectangular or square fields. And it wasn't good enough to conform the dose to a small spherical lesion. So some developments had to happen. The cones were designed. These cones are like tertiary collimations that produce very good conformity. The cone size or the aperture size ranges between like 4 or 5 millimeters up to, I guess, 4 centimeters. And they have very sharp penumbra. So we get high conformity of the dose and rapid follow-up, as I said. And they had to rotate the couch to do non-coplanar arcs. And they had to attach the patient's head to the couch using some rings and some kind of minimal invasive frames. And then after that, MLCs or micro-MLCs came to market. Leads that you want to use for a stereotactic treatment have to be less than 5 mil in width. Larger than this doesn't give you good conformity. When you have leaves around, not only you can do dynamic conformal arc, but you can do IMRT and VMAC, which is useful for treatment of cavities. Yes, in order to be able to do SRS with a LINAC, there are some key components. You need to have a reliable immobilization system to immobilize your patient during simulation and treatment delivery. There are multiple, a variety of thermoplastic masks available in the market. Open face masks are now out there, which are very comfortable for patients. But then you have to choose which one you want to use in your department, in your service. Then you need, not only in LINAC, also in Gammaknife treatment, you need multimodality, high resolution, and high quality imaging. We use, all the images that we use for SRS are 1 millimeter slice thickness, 1 millimeter slice thickness for MR, and also CT scan. And also you want to make sure that your MR images are of high quality, because all of the target delineation depends on the quality of the image. You want to control something very small, if the target which is very small, you don't want to have geometrical distortions in your MRI image. So you can have one of these phantoms. This is a fancy one actually, which has like a anthropomorphic phantom with a grid inside. You can scan it in your MRI imager and see how the phantom or the grid is distorted, and you can assess the amount of distortion in your MR image. Also, your LINAC has to be able to do high accuracy of target localization and dose delivery. Also, you need highly accurate verification imaging. You want to do mask treatments, you're not doing the frames anymore, so all the localization of the target depends on the imaging. So your IGRT system should be very accurately calibrated, and you should be able to rely on it. You might use your Condom CT, or you can have your stereoscopic Tbi imaging or optical tracking system like this one, Vision RT, which goes well with this open face mask. We use in our LINAC-based SRS, we use thermoplastic masks, and IGRT. Our IGRT system is mainly Exactrack. But as I said, masks are not as rigid as frames, and you are fractionating the treatment. You have day-to-day geometric target positioning uncertainty. And no matter how well you maintain your LINAC, there are always some remaining uncertainties. LINACs have some mechanical residual errors always. So in order to be able to make sure that the target is treated and you're not missing the target, you have to add a margin to your GTV or your CTV to achieve PTV. We, in our in our LINAC treatments, we add 1 millimeter of margin to our GTV or CTV to achieve PTV. But you have to assess this margin locally in your department, looking at your machine, looking at your imaging, and assess the uncertainties and decide what margin you want. So you need, actually, you cannot go very big, because if you put a large margin around your GTV, you get a big PTV, and you're actually going to ablate the normal tissue and put toxicity in patients' head. This is one of our LINAC cases. This was a multi-met, small spherical target ranging around 12 to 15 millimeters, to 16 millimeters. Our LINAC has a high definition NLC, which is 2.5 millimeter at center around the isocenter. These are the central lids, and you can see how beautifully they conform to the target. These 3 mets are treated using multiple arcs. The treatment of choice or technique of choice was dynamic conformal arc. We put 1 isocenter at each target. We are still commissioning our multi-met single ISO technique. It will be out there soon. But now at the moment we treat each target with 1 isocenter. And then we use 6 MV beams. We are commissioning our 10 3-color flat and frequent beam, which means the treatment will be much faster. We do our Exactrack imaging at each couch angle. We have 6 sub-couch, which allows rotation and translation at each couch angle. And that means when you rotate the patient, you rotate the couch, you localize the target, and you correct for the positioning errors. Exactrack is actually has 2 kV sources installed in the floor, and they are orthogonal, about I think 80 or 90 degrees angled, and the panels are hanging off the ceiling, and the images are reconstructed. We have DRRs at each couch angle coming from the reference data set, which is different from the planning system, and then X-ray images. The bony anatomy is the reference here, and we look at the bony anatomy to guide us to localize the target. And the rotation and translation can be applied with a very high accuracy to make sure that the target is localized correctly. This is a very interesting table, a very useful table from AAPM practice guideline, telling you how, when you QA the LINAC, what kind of tolerances you need to have, or your LINAC has to meet to make sure that it highly accurate SRS can be achieved. Not only every part of the LINAC will work really well, you want to make sure particularly that your IGRT system is accurately calibrated and your IGRT positioning error is less than 1 mil. Also, radiation isocentricity test. We do this test monthly as a kind of complete Winston test. We cover the whole range of the entry, couch, and collimator angles, and we make sure that the radiation isocentricity is actually within 1 mil. On the day of the treatment, or whenever we have an SRS or Saber, we do a mini Winston test on the day of the treatment with a limited range of rotations. And again, we want to make sure on the day of the treatment that LINAC can do the accurate job. Also, when you implement your SRS technique, the last step that you take is an end-to-end testing using an anthropomorphic phantom. You treat your phantom exactly like a patient, starting with imaging, image registration, and everything. And RTs are actually highly involved in this. When you treat, you deliver the dose to the phantom, and you measure the dose, and you make sure that the dose is delivered within 5% within 1 mil. Again, this target localization is very important. So in order to implement an SRS program, you need to make sure that you meet the technical requirements. First of all, your machine can do the job. If you have a proper MLC, if you have fixed-up couch is ideal to have. Imaging is a must. And you have to find a reliable immobilization system, a good thermoplastic mask that you can rely on. And then treatment planning system is critical. This is the main job for physicists to create the beam model, validate and verify. You have to measure your small fields. The profiles actually have to be measured accurately to characterize the penumbra, quantify the penumbra, and also you have to measure small field output factors. This is challenging. You can use TRS 483 from IAEA, which is a very useful document to do a good small field dosimetry. Also, you need to make sure that you have simulation spots available. Your CT and MR machines have a good protocols to go with your SRS program. For us, MRI is very challenging for Gammaknife because we want to make sure that once frame is installed on patient head, patient goes directly to MRI and the spot is available for patient, and the patient shouldn't be delayed. So availability of MRI and high quality MRI is crucial, and also for LINAC as well. The staffing requirement, you want to know how many RTs you need, how many physicists, how much support you need from everyone, from IT team, from everyone who's involved. And training and qualifications are important. You want to develop and implement your procedures. Quality assurance is also very important. Actually, you want to make sure that you have quality, you have patient-specific QA tools. There are very good phantoms around, arrays like SRS, MapCheck, or some other tools that you can look at and decide which one you want to choose, and decide if a treatment is safe before you deliver such a high dose on a patient. Then you do your internal audit, which is actually your end-to-end testing, and you can ask for external audit to give you an extra level of assurance that your treatment is safe. In Australia, we have ACDS. They perform an independent audit. They measure everything and they tell us how accurate we are. In conclusion, I've just put another list of targets that we can treat with Linac or Gammaknife, and see how widely SRS and program can be used. And the aim of the treatment is to improve local control, improve overall survival, improve quality of life, preserve neurocognition, and preserve neurological progression. This is the Gammaknife and SRS team. I feel like people who were involved in the installation of Gammaknife and implementation of SRS, basically. And yes, that's all from me. Thanks for your attention.
Thank you so much, Atousa. This was a great presentation and shows really the whole gamut of SRS treatments which are there. I very much like the last list of all the different cancers we can treat, and they all have slightly different doses, slightly different MRI appearances, and so on. And even more exciting, these targets extend to non-cancerous lesions. But that might be something for another time. We had a couple of questions on the chat, and I might just start with a first one, which is what is the minimum field size that should be modeled by the TPS for a stereotactic treatment? I assume that would be for a conventional Linac.
Yeah, that depends on the planning system. I know that different planning systems have different requirements. Currently, we are looking at one planning system, and what they require is down to 1 by 1. And we are actually providing our beam model, our Linac model, and the validated beam model, which is in the planning system, and like the gold beam model, golden beam model. Yeah, but that depends on the planning system requirements. You can go very small, maybe 1 by 1, or even smaller than that.
Thanks.
Yeah.
The other next question would be, what is the ideal or an acceptable gradient index for SRS with a Gammaknife? How fast do you go from, well, not 0 to 100, but from, let's say, 60 to 20?
50% to 25, yeah. Yes, we prescribe to 50% normally to cover the target, and then by definition gradient index is the volume which is inside the 25% isodose, or half of your prescription isodose divided by your prescription isodose volume. And we are typically looking for something less than 3. That's the golden number that we look at. But for some targets, it's not achievable. For some of the very small targets where actually like a pinpoint and your 4 millimeter is too large, you won't achieve 3. You sometimes get really bigger numbers.
Thank you. There are lots of questions coming in, and I think I'll ask another 2. What would you use a dose calculation based on MRI images or on CT data?
Is that a question for Gammaknife?
I would assume that it would be a Gammaknife question.
Yeah. Yeah, at the moment we use, you can use any data set to create your plan and calculate, because it's using a simple TMR10 dose calculation algorithm, which is everything is water. But our current version of planning system has a convolution algorithm as well, which is not implemented anywhere in the world. We just use it in some occasions where we want to check the effect of non-homogeneities. But yes, we can use MRI or CT scan for those calculations.
Thank you. And the last question I'd like to pose on behalf of the audience is one which always comes up and increasingly comes out, which is how many targets can be considered with LINAC-based SRS or SRT? I assume that's intracranial again.
Yes, I think it means in one section, or like treating all together, like instead of whole brain treatment, as people were doing before. Now you can do multiple, depending again on the planning system. I know that some planning systems, with the way that they optimize, they can go up to 20, or they show you some strange numbers, but you can do, I mean, they say they can do multiple. Yeah, I think at least a few you can do, but depends on how you trust your LINAC. Yeah, but with Gammaknife also we can do a lot. It doesn't matter for how many, depending on the dose. You don't want to go for very long treatment times, but we have treated up to 8 targets in one section.
Thank you very much, Atousa. There are a couple of other questions. We will try to answer these within the chat, but in the interest of time, I think we have to move on. At the moment, most of the treatments where we see many mets typically would go to the Gammaknife here at Peta Mac. But I think thanks again, Atousa. That this was great, and thank you all very much for the questions. We might move on from the brain. We are now going downwards, and the next lecture is about stereotactic ablative body radiotherapy, so not intracranial anymore, but within the body, or a Saber. And the most common scenario, if you look at patterns of care, then the most common scenario is really lung cancer. And that's what typically centers start off with, treating lung cancer, small lung lesions, be it either small stage 1, early stage primary lesions, or more frequently oligometastatic treatments. However, Saber has now been proven to be far useful, far beyond lung lesions. And the next speaker is Adam Yeo, who will talk about vertebral metastases and liver. And we've chosen these two because in patterns of care studies, or patterns of practice studies, in US at least, after lung cancer, the liver and vertebral mets are the second most commonly treated targets in Saber treatments. So we felt it would be probably useful, because they are actually a lot more tricky in some respects, to give a lecture about that. And I'm delighted to have Adam delivering that lecture. Thanks, Adam.
Yeah, thanks, Thomas, for your kind introduction. I apologize that I have only single screen working from home today. So can you hear me okay? Is it okay? Good news.
Yes,
yeah.
I can hear you well.
Okay, thank you. So I'll start the body part. So probably some remember the lightsaber, the hero of the world. So I keep referring to the saber, to the saber technique as a saber. So it's talking about something more than lung, especially we focus on the vertebra and the liver. So actually a number of our colleagues actually contributed. So it's not my own work, it's a collective work from our group. Here we go. So Atousa kindly covered the the brain part of it. Typically, we're talking about the margin of 0 for Gammaknife and 1 to 2 millimeter for SRS or SRT, depending on what treatment intensity you use. But now we're moving on to the body here, and the lung and liver and spine, all those, we're talking about the PTV margin, typically 2 to 5 mil. 2 millimeter maybe the bony met, including vertebral spine, or 5 mil or more for the moving lesions. So basically it's moving, also it tends to be very rigorous, very high dose gradient, so therefore it actually adds more value from physics perspective. So if I can summarize only one sentence, the take-home message is yes, by doing SRS also Saber, especially in the body part, physics can add more value and in the view of the clinical team. So we'll do Saber in Peta Mac. So have a look at the list of it here. So if you can see some lesion that you are treating but not listed here, please put the comments on it. So our experience from our department until actually the last year March, we treating about over 350 nearly courses, even though we are in the pandemic during this point in time. So the Saber till last March here, we just divided different lesions in the function of for the last 10 years or so. So most of it is lung, so we just move on to something else. So we focus on the liver and the vertebra, not the bony mat is excluded vertebral body Saber, which because the Saber has a lot more distinct features compared to other bony mat Saber. So how many Saber, vertebral Saber or spine Saber we're treating? It's just pulled out the data from here, actually till last October here. So actually it's actually increasing a lot. So in the average case, we're talking about 2 cases per month or 23 per year. But actually we anticipate it will come up more because according to one of the clinical trials, for example, it's SC24, the palliative Saber spine actually adds a value compared to the conventional palliative RT. So why Saber? Probably you don't need to memorize all those. This will be shared to you, but the primary purpose of this talk is about sharing our clinical evidence. So actually it would be helpful for you guys actually who are doing the liver and spine Saber. So typically we're talking about 2 fractionation, 20 gray in single or 24 gray in 2 fractions. The number of randomized clinical trial evidence is flooding in. So the whole take-home message from here is actually curative intent for the liver metastatic disease or the palliative purpose. Actually the Saber is being used and that there is some evidence coming in. So vertebral Saber, when you look at it, I would pick this case as the most complex, therefore most challenging scenario. It needs most value from physics in terms of plane check and optimization, and then physics measurements as well. So the spines here, and always our very sensitive zero OAR structures are overlapped with our PTB. Not only spinal cord, also surrounded by a whole bunch of different OARs. So the vertebral Saber actually highly complex shape. Also, it demands the most challenging dose gradient by its nature. So the distinct part compared to fractional or conventional RT, actually we are prioritizing OAR dose even over the target coverage. So we start from the CT simulation. With something to consider, immobilization is the key, I would say, and then some of the 3D CT or even 4D CT for the Saber. Why for spine Saber 4D CT? It's because not only the lesion is moving, but all the surrounding OARs, we really want to coat those or shape out those appropriately is moving around it. So we typically, the 711T spine, we do 4D CT with the appropriate immobilizations. So when this 4D CT, this is actually kidney case, but it's relevant for liver as well as spine. Can anyone actually pick up something's going wrong here? The quick answer is there's a lesion, that's the hint, but the superior and inferior part of the lesion actually moving more, but while the lesion itself looks static. So when you look at overlay the breathing trace here, in the 4D is actually irregular peaks there right at the lesion, like the patient scan sub-inf direction. So it's very unfortunate at that time that the breathing was very irregular. Therefore, motion is not tumor excursion is not captured properly. So the take-home message when you do 4D CT and QA of it, you have to check the breathing profile at that lesion. So it's better to know where the lesion is before you actually look at the 4D and doing the QA of it. So contouring the image guidance, so the spinal cord is the main OAR. So we don't really directly constrain to it because we know there's a geometric uncertainty from the motion aspects, also countering uncertainty and the planning, the beam model and RGRT, etc. So called PRV we do constraint to either it 1 millimeter, some centers using it, or 2 millimeter. It really depends on what sort of imaging modality you're using to define code. Also, it's coupled with RGRT capability. So if you have a very accurate IGRT and with very confident MR guided contouring of the code, 1 mil is sort of the tightest PRV you can use, but most of the Saber scenario, the 2 millimeter is a standard in our department. Also, if in case that the MR is not available for any palliative case, it's urgent treatment, and the bony canal is used. Typically, that actually more forgiving than code PRV. And other OARs, it really depends on which part of the spine you're using, the CT or L spine, and it includes esophagus and all the GI structures, including branchial plexus in some case. So the 6th of robotic cuts and X-ray RGRT is essential in order to deliver that. And we're using the exact track, and actually in Parkville, our campus, with a very thorough action level is a 0.5 millimeter, 0.5 degree, which is same as a SRS scenario. So the planning and optimization are, of course, different objectives you are using, because of the 1 versus 2 fractions. The reason why I populated here, as I mentioned earlier, OAR constraint is a higher prioritized compared to target coverage. When you look at is a code PRV, depending 1 or 2 millimeter PRV, the 12 gray smack bang on. So either you can argue that whether it's a point max dose or the voxel dose, 0.03 cc, depending on what kind of capability you have in place in your TPS. But typically 12 gray for single fraction, 14 gray to the 2 fraction. We really strictly the highest priority we are putting. Therefore, that's the most important priority, and then the target coverage priority coming it follows. So the planning and optimization, as you can see, is really highly challenging. Also, it's demanding in treatment planning and delivery point of view. Despite we're talking about the Eclipse experience only, the 2 or 3 arcs, up to 3 arcs, but most of lesions 2 arcs is sufficient as a full arcs. And the collimator, we make a mixture of the plus minus 5 degree and 1 arc, and also we have a second arc, actually effectively to spare the shape part, the spinal cord, and 1 arc can be the 90 degree. That's kind of the recipe we've been using. And the dose grid setting, we have to go down to some sort of the smallest, the most finest setting, if you wish, and the others, and that includes any moving OARs or any uncertainty in your surrounding organs. You better to put some PRV, for example, 3 millimeter in as an example, and that we constrain to it, not the direct or the intact OARs. Also, if you have the bowel structure, it's better to make the bowel back rather than intact structure, because it can move in different places between simulation and treatment. And so the message here, from the Nick's hardcast is a beautiful work. We've done the plan challenge for the Saber or vertebral spine. There are a bunch of different cases here. The take-home message is very complex plan, a very robust or simple plan can have the same kind of quality in terms of the scoring defined by the plan challenge case. So yeah, not necessarily most complex plan give the best quality. So how can you ensure that? So what we try to avoid here is unnecessarily modulated, too highly modulated plans. So in PNMAC, what we use a modulation factor definition, mu per fractional gray. So if you are describing 24/2, the 12 gray per fraction, we really don't allow the modulation going like 8,500 or so. Typically around the 5 or 6 modulation factor can make this in plan, and average leaf pay openings, that's a sort of surrogate of the how narrow the average leaf is, typically 10 to 15 millimeter. You can achieve this in plan. How do we QA it? Actually, we have a script to run, and even before that, rather than we check what is approved, sometimes we actually give the feedback during the optimization and planning. And our QA process is a mixture of the 3D virtual dose, independent dose check, also as well as the measurements. So we use Mobius, but the trick is the tricky part is our Acros algorithm, which is dose to medium, which actually deposit those have a noticeable difference in bone material, whereas our Mobius is dose to water, even though it is collapsed convolution algorithm. So you can actually see some discrepancy there, but that not necessarily actually the true. So we do use the 3% 1 mil type tolerance to check that. So delivery, we also check against the M3D to make sure the delivery is the same as what is planned. So when you actually calculate with those two water algorithms, so the reporting system same, actually much better matched. So that's not only one. So spine case is only one we measure with film for every single VMAT plans. So we use this so-called rod or mini rod, sort of the updated version. Rod is acrylic or PMMA material and a large and thorax size, and mini rod is sort of updated one. Now it's a water material and much easier to handle. So this one example is as a T-spine, the spine cord is wrapped around, and therefore it demands very high dose gradient and the setup, and then we actually have to apply cone beam before you beam on your film. So this typical example at the best case scenario, I would say it was happy. This is passed for QA, right? But that's not only always happen. So a lot of cases, the film batch has an issue, and sometimes you might need to attempt it to rescale, but you cannot rescale if there's the other absolute dosimetry information. So the way we design our the phantom, we have a point dose insert here. So actually that's a micro diamond. In this scenario, you can measure the dose accurately in those high dose gradient area. So we know if there's a known dose, we can renormalize to it if the film is off. So it's a choice of your department and the collective decision of what kind of QA tool we can use. So in our case, we check overall 3D dose distribution using our independent 3D dose calculation algorithm from Mobius. Also, we measure 2D plane, including spinal cord gradient, the interface. So I'll move on in 30 minutes. I'll move on to the liver saver. I'll get the question collectively at the end of the talk. So the liver it's still challenging, but with different reasons, right? So we'll cover some why we do the liver saver and what adds the value from the radiotherapy perspective. Also, we'll go through some of the workflow from markup prior to simulation and scanning and planning and GRT, etc. Okay. So anatomy to consider in liver. Okay, it's as complex as a spine case because the liver, you can't really see the lesion where it is, and we know it's noticeably it's moving and deforming. Not only the liver organ itself, but all the surrounding GI structures. It changes and gets deformed due to emptying and filling, and also the respiratory motions. And then all of those have a different extent of the radiosensitivity, which really need to take into account. So it's better to know what we're doing. So why liver saver? Liver saver actually works for both the primary HCC, also the liver mat. So I always quote this paper here. The take-home message is the most important number from the rationale of the liver saver is a BD 100 gray. Okay, the BD 100 gray is the clear difference in between for HCC in this scenario. If you can bump up those, so the BD can be over 100, we actually we see the noticeable change in total tumor control. Okay, so the BD 100 gray is the key term. Which is actually the abundant extent of the clinical evidence from the clinical trials. And not only the HCC of the liver mat, actually the same rule BD 100 applies, but actually even greater discrepancy between above and below BD 100 there. So actually the higher the more bumping up the dose actually have a better control rate. So what that means, if there's no motion, if there's a very small lesion, a small size, and we can minimize the dose surrounding liver or other way else, and it's desired to bump up those, make a higher prescription if we can. But the surrounding liver has its own constraints. So the liver toxicity is really well documented. It's in function of the mean liver dose here. So we have two conflicting factors here. We want to bump up those as high as we can. We want to GTV and IGTV, including the motion part, but also right surrounding the healthy liver. Actual mean liver dose is a strong correlation there in terms of the toxicity. Right, so therefore another key term here we're doing the liver saber is an isotoxic approach. Okay, we want to bump up prescription to as high as we can, as long as the liver is safe. The HCC, so that is a varying degree of the prescription. The 25 and 5 fraction, if there's any surrounding layers or lesion itself is very large, that's 25 and 5. It can be beneficial when there's no other surgical option or other TACE or radioablative options. So, and then the liver mean dose, what we're using here, that's published data. That's the in function of the liver dose with the how much liver or volume is getting for the liver toxicities. So the take-home message here, actually, if a liver mean dose, we can make it lower than 15 gray for the certain volume, which is 800 cc of the healthy liver, which is defined by liver minus IGTV. Actually, we have a quite good confidence that liver or the product organ wouldn't have a complication while we actually prescribe ablative dose. So in Peta, what we do, 700 is a bit more thorough than what is published here. So we use the 700 cc for the liver minus GTV as defined as a healthy liver case to receive 15 gray or less. That's the primary objective here. So what we know about the liver, so excellent local control strongly correlated to be the 100 gray. So it's and then it's well tolerated this ablative dose if the liver and surrounding GI structures are respected well during our planning and delivery processes. So therefore we liver saber, we use isotoxic approaches, and because the liver moves a lot, that isotoxic approach is very heavily dependent on what kind of motion management process we apply to. Therefore, physics can add more value in terms of simulation and motion management and IGRT, etc. Okay, so but the GI structures change position. So the strict fasting protocol, if the adjacent the OARs right adjacent to the targets or the healthy liver, and then we have to very thoroughly monitor during the IGRT and the planning process. So how do we deal with the simulation, imaging, and motion management and IGRT for liver and surrounding OARs? That's our cover for the rest of the talks. Okay, more than 10 minutes. I'm going well here. So I'll spend more time on that, how we deal with the liver. So before going through the technical details, it's an MDT approach. Really, it's not only the solo play from the team. It's really challenging, but actually can be done appropriately if we have a good team. It includes the clinician, RO, therapist, physics, and the nursing for the contrast, and diagnostic imaging, and then our radiologists, and the nuclear medicine clinicians and technologists as well. So it's a quite busy slides, but this is sort of the mock-up. It's called clinical mock-up. We perform as an MDT with a physicist and therapist in the machine prior to simulation. Basically, this is a before simulation. We have a separate appointment session in order to determine a patient capability of the motion restriction, I would say, the management, what kind of approach we use for simulation, as well as the other secondary imaging acquisition, also the treatment availability. Okay, so that's the markup is really an upstream issue to test the patient capability that affects all the downstream of the RT chain. So this is a bit outdated. So we want breath hold, so the static lesion, liver static, motion lesion static, so we can bump up those as high as we can, while we can limiting our liver mean dose. So that's the most highest priority. If patient cannot do a breath hold, probably you can reduce the motion during free breathing with abdomen compression belt. If the abdomen compression belt doesn't really work at all, so let's say, for example, 4 millimeter or greater reduction in terms of liver motion, which cannot achieve that, we might consider the free breathing, the gating around the exhale being, right? So all those, I'll just show a few examples how we determine that as a markup scenario on the machine. We use our linear accelerator. Fortunately, we have a luxurious stereotactic dedicated machine, so we're capable of booking some machine time for patient to go through the markup. So this is one example. The liver dome can be clearly visible in X-ray in the fluoro. So we measure that during the exhale breath hold. Also, it can hit the same spot in each breath hold. Also, it can hold long enough because that's a good surrogate. It's reproducibility or stability throughout the treatment. If patient can hit the same spot but cannot hold long enough, that's also not a good news, right? So, and then we also measured liver dome motion during the free breathing as well as a baseline. So our breath hold, can we do the DIBH or like our breast case or Y exhale breath hold, right? The typically DIBH, the patient can have a different amount of the inhale intake of the air. So the reproducibility wise, exhale breath hold, the airing out, actually can be a lot more stable or reproducible to hit the same spot when patient think is exhale with the breath out. Right. So that's the rationale about it. Unless there are special any cases to DIBH can add value, for example, getting the lesions away from central structures or heart or OARs. Apart from those special cases, the vast majority of liver, the EBH is what we try to achieve if patient can perform exhale breath hold well. There's a well-known supported by the Chris Brock's the work there, the reason why we're doing EBH against DIBH. So this is what we do during the fluoro. Okay, so the patient, this is fluoro during the DIBH here. So actually, there's a very minimal residual motion during the breath hold with a certain gating window, which we use with the RPM device invariant solution with a 0.2 upper and minus 0.1 as a lower in terms of RPM motion in and post direction. So the very minimal residual motion within the gating window for the exhale breath hold. Some patient, we think that our surrogate of RPM device, any other surrogate, is within gating or threshold, but internally the anatomy wide actually is moving a lot. So in that case, RPM is not a good surrogate as a measure of their liver dome reproducibility. So not all patient works perfectly. Typically, the obese or large patient, that's on the surface, things is same position, but they internally it actually is more, there's more chance to move. So the free breathing, this is one of the extreme case, actually up to 4 centimeters we occasionally see. That's how much we move. Imagine we try to treat this Saber without motion management, probably we cannot achieve the isotoxic approach as a Saber rule prescription. And the abdominal compression, if patient cannot do exhale breath hold, we apply abdominal compression in order to reduce the motion during free breathing. So there's no interruption on the beam. We treat throughout free breathing, but we reduce the motion. Even this is not preferred approach anymore from our clinical team because we know the free breathing gating effectively same as similar as exhale breath hold, but lower duty cycle. Actually takes longer to treat, but whenever it goes to free breathing, whenever it hits the free breathing at the exhale spot, you can beam on there. That's the next the goal option if patient cannot perform exhale breath hold. And there some patients cannot really go to the stable baseline in terms of exhale position. So in that case, patient cannot really do free breathing gating option. In that case, or the only option is abdominal compression case. And if abdominal compression doesn't add much value, so not much difference between free breathing with and without compression, and then only free breathing treatment is the remaining option. In that case, we have to reduce the prescription dose to respect the mean liver dose. So imagery, in that case, markups decided. So what can be done for the treatment, simulation and treatment. And so in that, this image registration is really key before we move on to planning, right? And there were some people actually question we can use a bunch of secondary images that I will show, and the deformable image registration can add value. But in our clinic, we are not really using that yet. Only we're using when there is a retreatment of the recurrence, and if we're doing the second or third liver Saber, we might want to have a more accurate deformable dose accumulation in terms of some dose. So ideal case, we want planing CT in the static position, and also we want the secondary images to visualize tumor for the target delineation on the same position. Right? So we have a contrast CT, MR, and PET, bunch of different secondary images option to see where the lesion is, because planing CT cannot see where the lesion is typically. So, so typically what we will do is we do contrast CT on the same position at the same acquisition session with the planing CT to have the best match on the same day on the same position. So I'll show you one of the example. The reason why the contrast CT is possible because the liver has a very unique dual duct the system here. So the contrast CT and the wash-in and wash-out process, there's a certain contrast difference in terms of uptake and then getting that out for the liver compared to its tumorous cells here. So this is the aorta. It's easy, very easy to monitor from the certain level where it's going through, and then there's sort of the contrast, the difference for the liver and HCC. So the white line here is a subtraction line between liver and HCC. So what that means, since it goes in the aorta and the liver dome level in terms of superior inferior direction, and there's a certain window, it's very valuable for us. We can take the quick scan, which is wash-in period here, about the 35 seconds, and another 20 to 25 seconds later, it wash out. So the wash-in, we call it arterial phase, where we really show tumor cell can take more uptake compared to surrounding tissues. It lights up, and then when the wash out, actually it have the hypodense in the cell compared to surrounding tissue. I'm talking about HCC, the primary tumor scenario, but also it's useful for a MET scenario as well. I'll show in the following slides. So this typical example of the HCC, the arterial phase, typically it's actually light, so where we can really see where tumor is. Without this contrast, it's very hard to accurately delineate the lesion. And so it gets a hypodense in the portal venous. So the both phases, wash in, wash out, are valuable in HCC, but the MET is easier. Typically portal venous is good enough. So I have a contrast in the washout phase to see where the lesion is compared to surrounding healthy tissue. So in this case, it's ideal. We want to acquire, for example, exhale breath hold. We want the secondary images in this exhale breath hold, where we want to see the lesion and control, accurately delineate the target without the blurring motion. And how can we accurately register that and transfer the target contour structure to planing CT? So we want exactly the same breath hold level in simulation. That's the ideal scenario. If we do the free breathing 4D CT, we match the breath hold level of the contrast image to one of the breathing phase of the 4D CT to transfer. So the people are tempted to use PET because PET is long acquisition, is a free breathing. None of patient or including all of us cannot hold the breath for that long. So there's by its nature, the 3D CT has a blurring effect in place on the 4D PET CT can be used for planning if that CT component from 4D PET CT scanner can be directly used for planning. And on the right side is a contrast CT as an example. So the PET is typically we use as a detection or diagnosis and the guidance purpose only. And someone really want to use the MR, but MR typically acquired a breath hold, but the inhale. So typically we use exhale breath hold for the treatment. So it's all the guidance purpose only as well. So as a summary, so IV contrast, which we always aim to acquire without motion blurring, which is breath hold, any level. Ideally exhale, patient cannot do any level of breathing phase. We want static liver motion acquisition with IV contrast, which can be used for accurate target delineation. So the contouring and the fusion and the motion management process is MDT approach. Okay. So we really add the value on there. But all the other secondary images, it's the guidance and the diagnosis purpose only in our departments. So quickly goes to one of some example scenarios. So dosimetry in this case. So typically compared to SRS case, we desire intentionally non-isotropic follow-up. So we shape out those distributions to certain direction, so we can spare surrounding OARs or healthy livers intentionally to the certain directions, right? So typically in this case, a full arc is not really recommended at all because we want 2/3 arc on the one direction. And also the collimator angle, non-zero angle recommended, so not to accumulate all those interleaf leakage throughout the VMAT delivery. And the modulation is really beneficial to shape out the dose against the away from the surrounding critical structures. And the prescription dose, max dose, typically goes over 125% of the prescription dose. So we intentionally put the hotspot. That's another distinct feature from the Saber planning compared to conventional RT, right? But despite we allow the very hot spot, but it has to be defined, located at the center of the GTV. So imaging slides have the very fine, if you can make it. So the dose grid should be similar as the spine case. We demand that very fine dose grid resolution for during the optimization as well as the final dose calculation as well. So imagine we have a plan. How can you accurately locate or visualize the tumor and then liver accurately on set before we put the beam on? So there's a bunch of the surrogate we can use, that fiducial markers, which is we implanted specifically for a liver Saber. There's some clinical trials going on in the globe, including Australian one. So also there's some residual from the surgical processes, lipidal can be used, but that can actually phase out or migrate. And the stent is, we strongly recommend not to use a stent because it's notoriously known that they can change the direction while independent from the surrounding actual anatomy. So the stent is not surrogate to monitor as a surrogate of that targets during the IGRT process. So the clinical example here, so as I mentioned, the liver Windows, so we have the script here. Okay, so what I would check, we check that, okay, healthy liver dose is well respected. Okay, and if there's only surrounding OAR, so they don't, what our second check is the optimization structure. They don't optimize directly to intact OAR, but they put certain margin, PRV around it. Okay, so it becomes robust to expected anatomy change between simulation and your IGRT cone beam on the day of treatment. So in this case, it's capable of EBH. It's ideal, also ideal because peripheral lesion. In this case, based on our experience, some patients cannot do the breath hold well due to the shoulder pain. In the left arm is okay to be down. The one arm up, which is the right side where the lesion is. So we don't want to go through the arm in terms of the beam pathway. We ask the patient to arm up on the right side, but left arm can be down, which actually make a big change that might allow patient to do external breath hold. So this is the phantom case, but a typical scenario how we do the gated cone beam. But my video seems not working. So imagine this is a phantom case, but that where the as I mentioned, upper is a 0.2 and lower is minus 0.1. Within the gating window, it actually beams on for the cone beam. So it's a gated cone beam we are taking. It really gives a really good workflow where we image where we aim to treat, right? So I'll move on. So the gated cone beam, really valuable. Imagine this is a case. We can't really see the lesion at all in cone beam before we hit the beam on. So how can you do that? So in this case, I'll say the liver dome is a really good surrogate to match to. So I'll call PDF. It's not the PDF document. The probability density function is basically the line profile. And then you basically match surrounding where the lesion is. So The y-axis, the HU, is not really important because the HU might be different between your cone beam and planing CT. But actually, the gradient here from the air to soft tissue of the liver dome, how the width, that's actually more important to ensure that good matching between cone beam of the day and the planing CT. Also, if there's any residual, the good surrogate or inside the GTV or nearby, even though it's outside, we can actually take that triggered imaging during beam on of the MV beam. So we can ensure that is within the predefined contour plus the fiducial plus a certain margin. Typically, we put 3 mm as a PRV to fiducials. So it can be really useful to ensure that we are hitting the target. So those are the examples. So what values we can add as a physicist to the MDT team for Saber and liver Saber programs. So basically, as a physicist, we can add a value throughout the radiotherapy chain from the start, even before simulation, to the IGRT and the treatment. So happy to take any questions.
Thank you very much, Adam. This was a whole school in 40 minutes. Very impressive, and a very broad coverage of lots and lots and lots of things overall. So thank you very much. I have a couple of questions in the chat. By mistake, I've already answered some of them. And I hope that this is actually useful for everybody in the audience. I might just pick up the last one, which hasn't been answered. What do you prefer for motion management? SGRT, surface guidance, or RPM-based motion management?
If you have all the SGRT system in place, potentially that can replace RPM, because which is a certain points or part of the body. But as far as I know, some SGRT solution is not really there yet in order to execute the breath hold beam gating scenario. Also, whenever there's a baseline changes, you have to capture it to get a reference surface again anyway. So that really doesn't give the smooth process, as smooth as the existing RPM scenario as of today. But in future, I look forward to further improvement. We can really smooth things out. So we can use the whole body, any area of interest in the body surface to use in order to enable the gating.
Yeah, there's certainly exciting changes, exciting technologies coming in, but not everyone has access to these things. And there was a really insightful question about any recommendations for developing countries where 4D CT and 6 degrees of freedom couch are not available. Do you have any pearls of wisdom there? That's fair comment. If there's no technologies available, whether they can really pursue Saber programs there, especially the liver and Saber. I would say there's a clinical needs and the demand for the patient. We can pursue, but really a cautious approach with appropriate margins. And the clinician needs to be aware of the increasing uncertainty throughout planning, also delivery processes. So at the end, the practical way is actually additional margin need to put on. That needs to be acknowledged by clinical clinicians. So I think it can be done. There are certain part of the world they are actually doing without 6-12 with a rigorous, or somewhat more time-consuming but longer process in order to achieve the accuracy on the delivery. Yeah, I think these are really valuable comments. And if there's no 6 degrees of freedom couch, then it just is inevitable that the patient needs to be set up more frequently. Or different immobilization may need to be used. In any case, now I think that was such an important message of Adam. The physicist must be part of this decision-making program, and it is really the physicists' input into these uncertainty analysis and the risk analysis, which will help to allow these treatments to be done by really a vast range of different technologies. in the interest of time, unfortunately, we have to move on. Please ask further questions. We try to answer them in the chat. And the last speaker goes from the small to the big. We are now moving towards special procedures with a particular emphasis on procedures which treat the whole body or the whole skin of the body. And I'm delighted to introduce Peter Lonsky, who's a senior medical physicist here at Peter Mac, and is working with the TBI and TBE team there. Over to you, Peter.
Thanks very much, Thomas. Hopefully you can see the slides and hear me clearly. And if so, we will get started. So I'm covering two topics today. I'll probably dedicate about 15 minutes to each of them. In practice, I think you could spend hours on each of them, but we'll try to keep to the physics aspects that are perhaps more exciting for us. So as Thomas alluded, we're looking at now a different kind of special in terms of special techniques. We've talked about SRS and Saber fields, so they're very small, but now we're looking at TBI and TBE fields. So this is quite a very different type of special techniques. So for this presentation, we're going to discuss some of the physics aspects of total body irradiation, or TBI, which involves large photon fields. And also then the second half of the session, we're going to talk about TBE, total body electron treatments. We're going to look at some treatment planning aspects of each, look at the treatment delivery and some of the technical considerations, but then also highlight some of the dissymmetry challenges, so those physics aspects that keep us physicists quite involved in these techniques. So for the first half, we're going to look at total body irradiation. So TBI is used in conjunction with chemotherapy in preparation for bone marrow transplant. So these are things like leukemias where a patient's got some sort of blood disease. We at VCCC at Peter Mac treat approximately 30 patients per year, which, comparing our workload to other centres, both locally, nationally, as well as internationally, makes us a relatively busy centre. And it's interesting to note that this workload did not particularly drop off during the pandemic. So this is still quite an important and relevant treatment option for a lot of patients. But being 30 patients a year, it's also quite a specialised technique. Despite being a very relatively busy centre, it's still quite specialised. So the aim of TBI is to give a uniform dose for the whole body. We're specifically targeting the bone marrow and circulating blood volume. There's a variety of different prescriptions used for this technique, 2 gray single fraction, 13.2 gray and 11 fractions, 12 gray and 6, and these are just some of the common ones. There are also a few different options as well. Just as there are different prescriptions, we also have various delivery techniques. So we've got just a quick example of some of the different options for delivering TBI, but this is by no means a comprehensive list. There's pretty much as many techniques as there are centres delivering TBI. For the most part, some of the common features involve large photon fields, lower dose rates, and in most cases extended SSD in order to make use of that photon beam, usually from a linear accelerator, but other units are also helpful. And if you do a quick literature search, you can see that there are a lot of challenges involved in trying to consolidate data for TBI patients, because every centre seems to be doing something slightly different. So not only do we have a variety of prescriptions, but we also have different techniques. And of course, a lot of the papers will highlight the resource demands for a TBI service. So just putting graphically some of these different technology options. So we can have standing TBI with a standard LINAC at extended source to surface distance. We can have a sweeping technique where the patient is static, but the beam is swept across the patient. We can have a lying technique, and this is particularly important if patients come to us who are too unwell to stand for a long time. Sometimes a lying option really is essential. And there's different options available as well, many more than I can put on this slide. So clearly set up in the technology can vary depending on your centre. So this is by no means a straightforward special procedure to deliver. Recently, Lottie Fogg and colleagues published on the results of a survey that was conducted throughout Australia and New Zealand. And this was sent out to all radiotherapy centres who are delivering a TBI program and asking them some relatively basic questions about their TBI procedures. This involved what dose are you using, what linac rep rate or monitor units per minute are you using, what source to surface distance are you using, and almost every centre answered something slightly differently. So this is just within Australia and New Zealand. So this really highlights how complex this can be. Between centres, you might get very different treatment techniques. There are some common features. 12 gray and 6 fractions seem to be a relatively common prescription. And although there's no agreement on the exact linac dose rate, you can see that a reduced dose rate is a common theme, even if we aren't all treating with the same dose rate. Does the radiation oncologist even consider dose rate important? Not at all centres, although mostly yes. And of course, a variety of centres either treating pediatrics or only adults. So I'm going to focus more specifically on the techniques that we use at Peter Mac, just because that's what I'm more familiar with, but don't take this as a definitive way of treating TBI. This is just what we have experience with. So we use two techniques at Peter Mac. We have a standing technique, and you can see here where the patient is actually standing in a frame. And this serves a few purposes. First of all, we can put a Perspex beam spoiler between the patient and the linear accelerator. And second of all, we have bars that sit under the patient's armpits to help stabilize them and gives them something to hold on to during their treatment. You can see the linac is facing the patient on its side. And for us, we use a 4 meters source to surface distance geometry. For the lying technique, we can also see a very similar theme with the linac tilted on its side and facing the wall. But in this case, we've got our patients lying in a TBI specific custom built trolley. This also allows us to have a beam spoiler degrading the beam between the patient and the linear accelerator. And for lying techniques, we either use a 2-field technique where the patient lies on their side for an APPA arrangement, or lies on their side as well as on their back supine for a 4-field technique, which is APPA, as well as 2 laterals, left and right. So these are 2 very sort of standard for us treatment delivery options. Here's another slide sort of trying to demonstrate the differences between these 2 techniques, showing also dose clouds from actual patients that we have planned and treated. So patients for us undergo a CT scan lying down in a supine position from the top of the head to about mid-thigh. So it's nearly a full body CT scan, as much as we can reasonably fit in. And then they are planned for us in the Eclipse treatment planning system. So you can see for the standing technique, patient gets a relatively uniform dose throughout their whole body, with the exception of these 2 regions or cold regions where the lungs have actually been shielded. So what we can attach to this Perspex frame of the standing TBI trolley is actual lung blocks, which helps us to reduce the lung doses to these standing TBI patients. On the other hand, you can see for the lying technique, the patient is actually scanned with a head compensator for the lateral beams, and that's to reduce hotspots in the head for the patient as well as the neck. You can see also a chest bolus, which is used to reduce the lung dose from the lateral beams, and various additional Perspex spoilers to kind of even out that dose distribution to any thin regions. So the legs, ankles, anywhere that's quite thin that would get a high dose is given additional Perspex compensation to even out the dose distribution. You can also see the Perspex beam spoiler added in the CT scan, which is included in treatment planning. So this is again highlighting the lying TBI technique in sort of a diagram format, with one of our RTs very generously volunteering to demonstrate the 2 lying positions. So you can see again for the lateral fields, we use our head compensators, chest bolus, and additional compensators for the legs. And for the ant post fields, the patient lies on their side, has a cushion or a pillow for support, and neck bolus as well as the leg Perspex blocks are used as compensators to reduce hotspots to those thinner areas, particularly here in the C-spine where we really don't want any hotspots as such. So for lying TBI, this for us is typically 12 gray and 6 fractions, although we also can do a 2 gray single fraction with an ant post-ant field arrangement, but 12 grain 6 fractions twice a day is our standard technique. So that uses 4 fields, APPA as well as left and right, and these are delivered in 2 sessions. The ant post fields would be delivered in the morning, patient goes away for a rest, and between 6 and 8 hours later, they'll come back for their left and right lateral fields in the evening, giving a nice break in between sessions. So as we mentioned, the head compensator and chest bolus are used for the lateral beams only. So the head compensator is to reduce hotspots in the head and neck area, and the chest bolus actually helps to reduce the lung doses. And Perspex screen is used as a beam spoiler for all fields. So at simulation, we have some specific guidelines for patient setup for their CT scan. So for a lying TBI, the patient actually has their arms resting on foam blocks, and we are intentionally here for the lateral beams, adding the arms in the beam path between the beam entrance and the lungs. So we're using the patient's own arms as a way of sparing their lungs from those lateral beams. And we can see also the head compensators, which are present at CT, although you can also add this as a structure in Eclipse, which is what we've moved to doing now. And the addition of neck bolus in the scan as well is also present. So this is sort of a typical dose distribution that we can achieve with a lying TBI. So you can see the neck region usually does receive a slightly higher dose, and this can be reduced further by actually increasing the thickness of that head compensator or adding neck bolus. But what we can also see is the sort of self-shielding effects of those arms. Why we have the arms in the beam path of those lateral fields is because we want to cool down the lung region. So that's quite important for us as well. So for us at Peter Mac, we have a choice of photon beams. We can choose from 6, 10 or 18 MV fields, and this is largely dependent on the patient size. So smaller patients, 6 MV will be adequate, especially pediatrics. We only use 6 MV for pediatrics. 10 MV is appropriate for most adults, but if a patient's particularly large, we might have to resort to using 18 MV. And I use the word resort because we do try to avoid it where possible because of those incidental neutron generations, which add additional dose to the patient that is not explicitly modeled. So only when we really can't achieve good dosimetry with 10 MV will we use 18 MV. We can reduce the lung dose for this technique by, as I said, those lateral beams through the arms, but also that chest bolus that the patient wears under their armpits. And we can reduce the neck hotspots with the neck bolus and the head compensator. So I mentioned briefly lung doses. There is data in the literature to suggest that lung doses and possibly even lung dose rates are important for toxicity. So on the one hand, we've got this data from Volpe et al., who subdivided their patients into those who received more than 9.4 gray mean lung dose and those who received 9.4 or less gray mean lung dose, and they could clearly detect an increased lethal pulmonary complication rate for those patients who received higher than 9.4 gray. Other studies have looked at similar dose levels. In this case, it was 8 gray mean lung dose, and despite a clear cutoff of follow-up time, there was some indication that a mean lung dose of 8 gray in this particular study was important for predicting overall survival. So while there are various different ways of delivering TBI, there is at least some evidence out there to suggest that sort of 8 to 9 gray mean lung dose is important for patient outcomes. So what can we do about that? Well, as I mentioned, we also do have the option of standing TBI using lung blocks and lung shields. So the downside to a standing TBI is the patient has to be actually healthy enough to stand for a relatively long time. This is about 30 minutes per session. Remembering, of course, that we have a reduced LINAC dose rate, and of course, there's some setup time required as well. So this is not going to work for all patients, but for those who are well enough, it's one option for shielding the lungs. These standing TBIs are treated with ant and post fields only, and you can see here in the diagram patients standing behind that Perspex screen, and hopefully you can also see those lung blocks attached physically to that Perspex screen. And you can also see in the lower photo the outline of where those chest blocks are from the field light. So what we don't want to do with TBI is shield any bony structures. So of course, any region of chest wall that's within those lung shielding blocks will actually be shielded unintentionally. So what we do is we actually boost these areas with an electron field to hopefully cover any residual diseased blood cells that are in those chest wall regions. So here you can see a CR cassette image, which is used for treatment verification of those lung shielding blocks. The CR cassette sits behind the patient. We take an image at fraction 1, and here you can see the outlines of those lung shielding blocks, and you can also see the patient anatomy behind that. So here we just want to shield the lungs, but we don't want to encroach upon those chest walls. Or you can almost hopefully make out here that clavicle as well. That is a part of the target volume. We do not want to shield that clavicle, which is why you can see how those lung shields sort of dip in the medial aspect. We can also see a slight outline of the lung, so we are not shielding the spine or the chest wall, just that middle part portion of the lungs. So does lung shielding actually help? What difference are we making to the dosimetry? Well, we've done our own in-house study recently, and this is in preparation, though it's not published just yet. But what we can see is that relative to the prescription dose, all of our lying techniques, regardless of the dose, receive between 100 and 110% of the prescription as a mean dose to the lungs. And that's even with chest bolus. So it's quite difficult to spare the lungs with a lying technique. Our standing TBI, however, with lung shields reduces the relative mean lung dose to about 75% of the prescription. So there's clearly a benefit there to the shielding blocks, even with the addition of those electron chest wall boost doses included in that lung DBH. We do, however, need outcome data to see whether this actually makes a clinical difference. That's works in progress, but at least for now, we can see that the shielding, despite being additional work, does actually reduce the overall mean lung doses. So some of the TBI challenges, we're obviously dealing with large fields, and dosimetry depends on the environment, by which I mean the Linac bunker. You've got scattered conditions from the wall, floor, ceiling, any equipment that you're using. So in our case, in the TBI trolley, so this is where physics really have to get in there and measure under clinical conditions, even in just a phantom, what are the scatter conditions in your Linac environment for your specific setup. Never assume that a treatment planning system that's commissioned under standard conditions can also model the dose at extended SSD. So the TPS itself, the treatment planning system, requires very careful commissioning to make sure that it is appropriate for use in these non-standard scenarios. For the measurements themselves, there's sometimes ion chamber issues to consider. So what is the leakage current in your ion chamber and electrometer relative to this now relatively lower signal at extended SSD? You are irradiating a very large area. So you've got cable in your field. What are the extracameral effects? So there's some good physics in there, but a lot of additional considerations for these non-standard conditions. At commissioning, you need to also consider a backup machine. If this Linac goes down that you've commissioned for TBI, you need a backup plan because the patient cannot simply miss their evening fraction, for example. In vivo dosimetry is a very common feature in TBI. A lot of centers are doing it, even if there's no consensus as to how best to do this. Some centers are using an ion chamber in the field. Some centers are using MOSFETs or TLDs or diodes, especially when the service is new. So in vivo dosimetry is quite important for TBI. You also need expert staff and the associated resources. So RTs who are familiar with patient setup, physics, in our case, physics do the treatment planning. We can also be present for unusual TBI setups, and the radiation oncologist, of course, and if appropriate, hematologists and transplant surgeons. So it's quite a multidisciplinary team requiring some specialist knowledge. What's the future of TBI? Well, large open fields have been quite standard for a very long time, and that tends to be what we have most experience with and what we're most comfortable with. But a lot of centers are now looking at more exotic means of delivering TBI. So that could involve multiple isocentered VMAT, thermotherapy. Some centers are using total marrow irradiation, at least in their planning studies. I haven't seen that widely used clinically though, but it is technically feasible from a planning perspective. Some clinicians are discussing the risk of missing circulating blood volume. So as you're irradiating parts of the body, you're actually potentially missing circulating cells, but again, there's not a whole lot of evidence thus far. It's still in sort of a technical feasibility stage. Need to consider dose rates, timing of radiation with circulating blood, lung doses to shield or not to shield. Obviously, this will depend on each individual center. And of course, there's plenty of opportunity for us physicists to really get involved and make a difference for these techniques. So I'll just finish off by talking about total body electrons. So TBE comes with different names, but it all means the same thing. So you could say total skin electron therapy, total skin electrons. There's a whole bunch of other acronyms as well. It all basically means the same thing. And in very simple terms, it's basically TBI, but for skin treatments. And we'll talk about what exactly that means. So the clinical indications for TBE, we aim to irradiate the skin and spare all the remaining underlying tissue. So you can imagine that's quite tricky. Commonly, this is used to treat mycosis fungoides and a few other rare skin conditions as well. And you can see that these diseases can actually be quite nasty. So this is a photograph of a patient who was diagnosed with MF, mycosis fungoides, and you can see these really sore red-looking lesions. But you can also see the photograph of that same patient after TBE treatment and just how effective this can actually be. So it is really an important treatment option for those who might not otherwise have many options, especially when this is widespread throughout the whole body. So the dose distribution is ideally uniform, and there are various methods available by which you can deliver this TBE. A typical prescription for TBE is 30 gray in 20 fractions in 1.5 gray fractions. I've seen a few variations, but that one seems to be the most common. So what does this sort of target volume look like in treatment planning terms? Well, if I had to loosely draw it, it would look something like this. The CTV is the whole skin surface from head to toe, and everything else underlying is the organ at risk. So this is actually a very complicated volume to be treating. There are different options. There's a translational option where, especially if you've got a patient who cannot stand, you can slide them underneath a static beam. There are large static field options where you can use a spoiler actually to degrade the beam. So a patient stands behind a screen and you can beam an upper field and a lower field to cover the whole body. Or there's a rotational option. So that's the photo down the bottom where a patient stands on a platform that actually rotates while that beam is on. And this technique is quite nice because it exploits the electron PDD under a rotation in order to achieve Dmax at the surface. But let's just explore, what do I actually mean by that? What am I exploiting in terms of electron PDDs? Well, hopefully this is a familiar image to you. This is a standard 6 MeV beam in a 10 by 10 field that I've exposed on a piece of film and have scanned that out. So you can see that Dmax is occurring at about 1.3 centimeters, and you've got your practical range down at about 3.1 centimeters. You can see those bulging electron isodose lines, and hopefully this is a familiar sort of image to you. But this is under normal incidence. So what actually happens if I angle my beam and come at this slab of solid water at an angle? What actually happens then to my isodose lines at depth? So what we see with electrons is that at normal incidence, if these are your isodose lines at depth, as you're increasing the angle of incidence, you're actually shifting your depth of maximum dose towards the surface as those bulging isodose lines start to overlap. And what we can actually see is that in action, here I've measured a TBE PDD under a full rotation with a piece of film. So you can actually see that my normal 6 MeV beam now has a Dmax at the surface under a full rotation of a rotating phantom. So that's what we're exploiting here, because that's exactly what we want to do. We want to treat the skin and try and spare as much as possible any underlying tissue. So at Peter Mac, we use this rotational technique. The patient actually stands on this rotating platform, which is controlled from outside of the bunker. The linac is angled sideways to face the patient who's near the wall. And the patient stands in this turntable and holds onto these handles. And we can actually alternate the patient's arm position every fraction. So on one fraction, they might have their right hand up, On the next fraction, their right hand will be down, and that's to sort of even out those cold spots that would otherwise be occurring if the patient stood in the same position every day. So we use an upper field, which is then complemented by a lower field, and each of those two dose profiles will combine to create a large profile sum. So you can see what I mean by that. These are two individual TBE fields, an upper and a lower. And we can also see the combined sum of those two fields, which is our final TBE field profile, which is really large. We're covering 2 meters, which is really effective in treating the whole body. We can see also a slight peak in the center of the field. We could control this. If we wanted to, we could flatten that out by increasing the separation between the two fields. But what we find is that the torso of the patient, so the thorax and pelvis, is usually a bit larger compared to the thinner areas, so the legs and the arms. So the torso is usually a bit more self-shielded under rotation compared to those thinner parts of the body. So we actually want this peaked dose profile to occur on that otherwise cold region of the body. So what we find is this 10% higher dose in the peak of the profile actually works best for us and gives us more uniform dissymmetry. So some familiar challenges associated with TBE. We're again talking about large fields. We're also talking about low signal to our ionization chambers as they're used in the field. We're also, again, dealing with that familiar extracameral signal as a lot of cable ends up in the field. We also, of course, need to include in vivo dissymmetry, but a unique challenge associated with a rotating TBE is that there's no planning system that will calculate for you the dose to a rotating body head to toe. First of all, we can't guarantee the patient will hold their arm in exactly the same position. We would need a full body CT scan in 2 sort of positions, and you would need to, potentially the only option is to have lots of individual fields simulating that rotation. So at the moment, there's no good planning system data that will simulate a TBE treatment. But this is important because we are expecting some cold spots. So how do you accurately assess the dose distribution over the entire body and inform cold doses, which eventually, at least in our case, get boosted at the end of treatment? So really the only good option that you have is in vivo dissymmetry, and certainly our TBI program relies very heavily on in vivo dissymmetry. So this is used to help define those boost areas, not just their location, but also by how much. What is the prescribed dose to those boost areas? How cold are they? It's also fantastic as a routine QA tool for our TBE service, because if you consolidate all your patients who are undergoing TBE and monitor that data, you can look for any trends over time. It does require ongoing monitoring, and in our case, lots of TLDs for every patient. We have 26 standard positions that we measure over 2 fractions. So it is a bit of a workload, but again, it is essential. There's no other way of reporting the dissymmetry to these patients. So we monitor not only the prescription dose, but also the dose to any organs at risk. And here in this example, you can actually see the patient has these bits of tape on the end of his fingernails. These are actually lead shields that we have strapped to each of his individual fingernails, because if you don't shield the nail beds, they sometimes fall out, which is a bit of an unpleasant side effect for these patients. So in cases where there's no evidence of disease around the ends of the fingers, we will actually opt to shield the nail beds. And similar with the eyes, we will actually add eye shields if there's no disease around the eye area. So this is a TBE patient who has undergone his treatment, but is then getting his boost fields to those cold areas. Some very common cold spots are the tops of the shoulders, inner thighs, as well as the scalp, which is obviously very difficult to irradiate when a patient is facing the linac. So those boost fields, the prescription of those are informed by our in vivo dissymmetry. So this is what it looks like to consolidate all of your in vivo dissymmetry data into one place. So you can see the measured dose in gray, and we can see the prescription region. And there is obviously a lot of variation in the dissymmetry depending on the parts of the body. So the scalp and the scalp vertex, for instance, will get a cold dose. This is a known or an expected underdose. Tops of shoulders, again, they're sort of self-shielded to an extent. And these are right and upper right and left upper medial thighs, which again, depending on how wide the patient can stand, their legs apart, will receive an underdose as well. The prescription regions, this is the torso, the thorax and abdomen. You can see that there's a slight underdosage. This is something that we're aware of and that the ROs are comfortable with. We have got good outcome data. If we were to boost the overall treatment, we would start to get even higher doses to these other areas, so the elbows and the feet. So at the moment, the ROs in our case are not keen on changing anything at this stage. But again, this is fantastic data, great to monitor, and something we can keep an eye on and adjust if appropriate. So I'll just finish off by making a quick note on Bremstrung photon contamination. So even though we're dealing with electron fields, you do also have to consider that there is photon contamination as a result of interactions within the scatterfoils in the machine. So you can see here we've got an electron PDD under standard conditions, so 100 SSD for a 6 MeV. You can see in red. And in black, we've actually got a PDD for the same beam, but at our 3 meters SSD, which is what we use for TBE. So two features you can see. First of all, a degradation in beam quality, as you would expect over a large distance of air. But also you can see the Bremstrung tail, that photon contamination has actually changed. And if we zoom in on that part of the graph, you can see that compared to the standard 100 SSD, the photon contamination has actually increased slightly. And at least in the case of a Varian machine, you can see that if you were to scan across the profile of your Bremstrung photon contamination, that the profile is actually peaked. So the core or the center of your patient is actually receiving that extra photon dose throughout the entire course of their rotational treatment. There's not a whole lot you can do about this, but as physicists, it's great for us to actually explore this, have the data on hand, and have that discussion with your radiation oncologist just to be aware of it. There's not much you can do about it. You can't effectively shield it or get rid of it. It's just something that's a little bit higher than your standard settings that's just to be noted and explained. So some take-home messages from this session. TBI and TBE are very important treatment options for our patients. They do both have some significant resource requirements, but also some unique dosimetric challenges, which are, I think, exciting for us physicists in a way. But in vivo dosimetry, I would argue, is very important for verification for both of these techniques. And thank you all so much for sticking around to the end of the session, whether it's evening or morning. And if there's anything I haven't covered that needs to be explained a little better, feel free to email me and I'll try to get back to you. Thanks.
Thank you very much. That really ended the school very, very nicely with a cup of coffee. I think there are, again, a couple of questions in the chat. Thank you very much for your questions and engaging, and particularly to hang around. This has been actually a rather long session overall, and I'm delighted that you're still here. I might just ask one or two questions of Peta before we close. Do we have to take extended SSD output for treatment time in calculation, for treatment time calculation into consideration?
I'm familiar with monitor unit based, but I assume if you're talking about a cobalt unit, for instance, yes, that would have to be taken into consideration as well. Yes.
And maybe sort of related to that, how do you measure initially the dose rate or the number of monitor units at extended SSD in a rotating body? What physical measurements did you do for the commissioning?
Yeah, that's a great question. It was full of challenges. My approach was to throw everything at it. I used TLDs in a rotating phantom. I actually used an ion chamber on a rotating phantom, and I used film wedged between two slabs of a cylindrical phantom. But to get to that end-to-end type of testing, I actually started basic and did a sort of a daisy chaining method. So I changed one parameter at a time. First step is, because we're not using electron applicators, what's the output without an electron applicator? Then you extend your SSD and then you add the rotation. So every step of the way, you're verifying that the changes you're seeing do make sense, because it's very difficult to be confident when you're suddenly throwing everything unusual at your detectors. So I would, if I had to make a recommendation, I'd say change one parameter at a time and measure your output. Does it make sense? If so, great. And kind of like SRS, have at least 3 different detectors for your final verification would be my advice.
Thank you very much. And also to bring that back to the SRS at the start of the treatment, I think this is a great time to close the session. I'd like to thank all the 3 speakers, Atousa, Adam, and Peta, for what I think, and I must admit I'm biased because I obviously work with these wonderful people, but I think it has hopefully given you sort of a bit of an impression about the more special procedures we're trying to bring physics into the interface with the clinicians. I think we leave it here. What I will do is I will ask the organizers to send out the questions for all of the sessions to all the people who have been registered. And then I hope you find the questions after the lectures very easy to answer, and you can send me the answers. I'm keeping score and I will keep you informed. So with that, I hand back to our chair, Professor Shugul, and thank you all again for your participation.
Thank you, Professor Tomas, for organizing an excellent AFOMP school. Thanks to all the speakers, Atousa, Adam, and Peta, for covering the topics they have been allotted very nicely, generating a lot of questions from the participant. But because of the time, all the questions could not be taken. And as Thomas has suggested, definitely we'll do that. And also the questionnaire, the feedback questionnaire, what he's going to prepare, what he has suggested, that will send to all the attendees of this webinar. So thanks again, once again, Professor Tomas and Atousa, Adam, Peta, for this great job. And as AFOMP is continuously organizing the AFOMP school as well as AFOMP monthly webinar. And the next AFOMP webinar is on 11th February. This will be by Sian, moving from functional alignment to an anatomical alignment of radiation oncology medical physics services. And this will be moderated by Dr. V. Subramani from AIMS, India. The flyer will be available within 2-3 days on the AFOMP website, and then the link so that people can register who are interested into that thing. The again in February we have the AFOMP School Webinar. That's the second webinar, and that is medical physics and nuclear medicine physics and beyond. And that will be on 26th February 2022. Already the flyer is on the website. The registration link also is there on the flyer. One can register, and these are the 4 esteemed speakers. Then we have AOCMP 2022 in Taiwan, December 10 to 12. Adapt to change, explore together is the theme of this conference. And we see and we hope that the world will come to normal and we'll be able to meet in person. Before that, we have the triennial conference of the IUPASM World Congress during 12th to 17th of June 2022 in Singapore. This conference is in hybrid mode. People who can attend in person, they can. If they cannot attend, they can join in virtually. So these are the activities AFOMP is undertaking. Other than that, a lot of activities you can see on the AFOMP website, awards and other things, AFOMP newsletter. So once again, thanking the Professor Tomas and his team for excellent AFOMP School Webinar, all the delegates for actively participating, Jin Xians, our chair of the Education Training Committee, and Chai Hong, the chair of the PRC, and Rajni Verma for helping out and making AFOMP activities successful. Once again, thanking each one of you, and see you on 11th February for the AFOMP webinar. Have a nice time. Have a safe time. Thank you very much. Thank you. Bye-bye. Thank you. Thank you, Adam. Thank you. Excellent. Okay. Bye, Atousa. Bye. Yeah, good. Thank you.